I think that stroke treatment, approach to stroke treatment and diagnosis has evolved tremendously in the past couple of decades, going from a single medication that we have available through FDA, such as IVTPA, to advancing additional treatments such as mechanical thrombectomy with very effective and very effective devices and very efficacious treatments. The next step would be to generalize these treatments, because obviously, as we mentioned, the mechanical thrombectomy could be only applied to a smaller population of strokes. So how could we still preserve the brain that is potentially salvageable? How can we apply these treatments not only in the middle of academic, populated centers such as Boston, but how can we bring it not only to rural United States, for example, but also to developing countries such as India, Pakistan, Sub-Saharan Africa, where incidence of stroke is very high and actually diagnostic and treatment options are incredibly low. Current research that is focused on understanding the mechanisms of salvageable tissue that is still potentially survivable, under the circumstances, how to improve the survivability, I think has a lot of hope. Also, the research that focuses on outcomes after stroke is also very important, because many of strokes we still are not able and may not be able to prevent, under the realities of all the circumstances around the globe. So, how to quickly intercept the process in the brain that perpetuates the worsening of the symptoms, and how to improve the early recovery. That type of research is also promising. It takes time to find this answer, to bring diagnostics and treatments, but sometimes all it takes is this momentum that builds up. So for all we know, there may be now a research that's about to break through. There's a very known phenomenon in scientific field where there's kind of a plateau in certain areas, and then all it takes is one big discovery, like in the 70s and 80s discovery of CAT scan and MRIs, or in the 90s and 2000s genome-wide genotyping, things like that. Basically, bring the development of therapeutics and diagnostics to a tremendous spur. And who knows, if we continue our diligent work on a daily basis, tomorrow may be the day when we bring a discovery to fruition. I think it really tests your clinical common sense as well as your understanding of clinical data. For many years, even in the absence of systematic evidence, we suspected, and we had anecdotal evidence that this therapy works. But what we also knew is that it really, specific patient population that this therapy works. And so in many of the centers, despite the results of the clinical trials that came out 3 years ago, there was just kind of everyday thorough work trying to develop this selection criteria, mobilizing the field, trying to keep the composure in the sense of this fluctuating evidence until we were able to get the correct, identify the correct patient population, until there was a breakthrough with the new, interventional devices, and until the community came together to be able to enroll patients, at the appropriate pace to allow this discovery. Yes, so every intervention comes with a small risk, obviously, and the risk really varies at the level of the operator's proficiency. Luckily, over the past couple of decades, the field of neurointerventional neurology or neurointerventional field actually had come through, forward quite significantly. In fact, in the United States, in addition to neurosurgeons, interventional radiologists, there is a large group of neurologists who have been trained in neurointerventional science, and these individuals are actually performing at the very high level of quality. With that, each procedure carries a risk of complication, but based on the results of the 5 trials that we have seen so far, the complication risk is relatively low.